All
And I'll
right,
take care of the letting people in so you can do the hosting.
thank you. Okay, I am Allison Landolt. I am the president of the Endometriosis Foundation of Houston. I am joined today by Melissa Persia. She is our director of fundraising and development, and we are very happy to welcome Dr. John Dulemba today. Dr. Dulemba, thank you so much for joining us to do a talk on adenomyosis and endometriosis. Dr. Dulemba is a world-renowned, board-certified gynecologist who's considered to be one of the leading experts worldwide in state-of-the-art Da Vinci robotic surgery. He improves the lives of people who come to him for care at the Women's Center in Denton with a wide variety of innovative, minimally invasive surgeries using the Da Vinci, as well as top-of-the-line supportive treatments. His specialties include alleviating endometriosis, adhesions, and pelvic pain, and he only provides services for these particular problems. His reputation as an innovator attracts people from around the world to the Women's Center for expert and cutting-edge care. He always takes time to educate his patients on the therapies they receive so that they understand each step of their journey toward wellness. Dr. Dulemba is a former helicopter pilot for the United States Army, and he earned his MD at the University of Pennsylvania. He is an avid Pittsburgh Steelers fan and is often known to enter the OR dressed in his Steelers attire, as he is today. Thank you so much for joining us, Dr. Dulemba. So Dr. Dulemba is going to talk. If you have questions, we'll try to get to them as we go along, and then we'll have a few minutes at the end as well for any questions that we don't get to during his presentation. But if you come up with a question, feel free to just shoot it into the chat box. And on that note, I'm going to hand it over to you, Dr. D.
Thank you. Thank you. Thank you for that introduction. The first caveat I like to give everybody is that I am oftentimes a little bit different than most of the other thought processes and actions of other doctors. So you don't have to agree with me. You don't even have to believe me. But I do urge you to at least keep an open mind. And in this way, you'll have some other things to look at besides just the Zoom pictures that are on here. Now, of course, last month was Endometriosis Awareness Month, and of course, this month is Adenomyosis Awareness Month. And of course, the first thing is there seems to be in a lot of doctors' minds and a lot of scientific studies a difference between endometriosis and adenomyosis. In my opinion, they're the same. Why does it have a different name? Well, many years ago, endometriosis used to be called endometriosis interna. And I just want to share a screen right here and just show you the article that's on here. I think everybody's seeing it. It says adenomyosis, endometriosis interna are enigmatic diseases that has yet to be discovered. Well, when it was called adenomyosis or endometriosis interna, it confused doctors. I oftentimes say in a joking manner, but there's oftentimes truth to a joking manner, is that we as doctors aren't that smart. So we would get confused. They'd go, wait, isn't endometriosis interna everywhere else? So they decided to change the name. So let's look at the name itself. Adeno is Latin for glands. Myo is Latin for muscle. Osis is Latin for where it doesn't belong. It's glands in the muscle where it doesn't belong. I'm sorry, that's endometriosis. And of course, if you look at everybody's description of endometriosis and adenomyosis, from the majority of the doctors, I haven't listened to any of the lectures given on here, but almost every article I looked at, just looking at endometriosis interna and adenomyosis, they always say it is the lining of the uterus that gets where it doesn't belong. I'm sorry, that is not a description of endometriosis, let alone adenomyosis. Because endometriosis, I found in patients that are born without a uterus. never had retrograde menstruation. There's men taking female hormones that get endometriosis. They've never had retrograde menstruation. So we know that there's many different ways that endometriosis can be there. And in my opinion, retrograde menstruation is probably the least likely of that happening, because these cells are too abnormal to just think that they're dead, sloughed off cells that come through the fallopian tubes and turn into devil dogs on the inside of the abdomen. No, that can't be, because there's too many abnormalities with these cells to actually correlate retrograde menstruation with a disease process. So with that in mind, look at what they say, who gets adenomyosis. They go, women that have had C-sections, women that have had D&Cs, or women that even had vaginal deliveries, or they're older. I'm like, wait a minute. I've seen 14-year-olds with adenomyosis. They've never been pregnant. They've never had a D&C. They've never had a C-section. Again, we hear things, we publish things, and they don't always mean that's what it is. You have to put common sense with it. So that's my take on the disease of endometriosis. Looks like we have a question already. Is endometriosis excision surgery recommended for people with adenomyosis, even though at least some pain will likely persist? Yes, for one, you still have to get rid of the disease that you can get rid of. And then there are things that you can do, and we'll talk about that later when it comes to treatment options. But to try and ameliorate the symptoms of the disease. So yeah, why would you want to leave disease that you can get there floating around, not floating, but inside the abdomen? So yes, you want to get rid of the disease. So back to where we were talking about. So what are the symptoms of adenomyosis? Of course, very similar to endometriosis. There's pain. You can have uterine pain. You can have heavy and irregular periods. You can have lower back pain. A lot of times patients might have front thigh or inner thigh pain or back pain. Why would you have inner thigh or front thigh pain? Because there's some ligaments that come off the uterus, the fundus or the body of the uterus. And they go through a canal, and those ligaments implant on the bone in the front of the pelvis. And of course, if there's adenomyosis and there's inflammation, that ligament is going to hurt, and patients are going to see front thigh or inner thigh pain. Not everybody asks about those questions, but when you have those symptoms, and it's on both sides, that leans towards the adenomyosis, in my opinion, symptom-wise. It's if they hurt on one side or the other, then sometimes you can say maybe it's some other entity that might be causing the pain. But if it's on both sides, it's usually that disease. So one of the questions then, along with the symptoms, is, well, what are we going to do for this disease? Well, for one, to tell you the truth, every article that I was refreshing on, just to make sure I had the right thought process for what other doctors are saying, and almost everybody talked about adenomyomas. And I've seen them, but not as often as the papers and the discussions are. And what is an adenomyoma? An adenomyoma is just like an endometrioma, just a big glob of adenomyosis. In my opinion, an adenomyoma is a little different than an endometrioma, because an endometrioma is oftentimes blood. Most of it's blood. If you think of an ovary, it's not loaded with endometriosis cells floating around there. No, that's old blood. That's why it's sometimes difficult to distinguish an endometrioma from a hemorrhagic cyst, because they're both blood and the density looks the same. Well, in an endometrioma, you have a capsule that can actually be peeled out of an ovary. And whereas an adenomyoma is a large conglomeration of glandular and stromal cells inside the the uterus. And oftentimes, if they're thick enough, can be mistaken for a fibroid uterus or fibroid, and sometimes they are difficult to see. So one of the other issues with adenomyosis is, how do you diagnose it? Well, even when I explain this to my patients, the first thing after surgery is, did you see adenomyosis? I'm like, really? Have you ever looked, and this is a rhetorical question because I assume most people have, ever looked at a watermelon? Can you tell if there's seeds in the watermelon? Well, no, but you can tell, you know that there's seeds in there. There are ways before surgery that can give you a much better aspect of trying to find this disease. So when it comes to evaluating the pelvis, the worst imaging for the pelvis is a CT scan. And of course, if you go to the emergency room in the middle of the night, you get a CT scan. Okay. Because think about it, you have a big hip bone there, right? And trying to get radiation through that bone to get accurate and precise information in the pelvis is not the best way to evaluate the pelvis. But every general surgeon that wants a CT of the pelvis, no. The better test is the MRI. Because in MRI, the magnetic field doesn't pay attention to the bone. You can see extremely accurate, precise information in the pelvis. So you can see some adenomyosis with the MRI. But the more informative is a properly done problem-focused ultrasound. You notice I said properly done, because I'll even give you a story along with this. And I didn't learn this. This is what was taught to me by my sonographer. What happens is when you're doing the ultrasound, especially the vaginal probe, you can do it abdominally, but correlating the two, abdominally and vaginally, can give you a lot of information. The uterus is a muscle, and muscle has a specific density. And so when you can't really do this other than maybe the liver. But, although I do have a couple patients with endometriosis in their liver, we don't routinely just, look for endometriosis up there in every single patient. But the uterus has muscle. And if you send sound waves through there and dial in the gain, in other words, it's the amount of denser density for that gain, for that muscle, and it's sending the sound wave through there. So it doesn't recognize the muscle. It's like looking for a submarine in water. Of course, growing up and even now, I still watch a lot of war movies. So for people out there that don't watch war movies, they do sonar and they look for a war machine or a big fish or anything. They send sound waves through the water. And it's going through there, and it's not, the sound wave isn't affected, but when it hits something of a different density, it changes the sound wave. And it's the same thing. When they're sending the sound wave through the muscle, it's not paying any attention. And all of a sudden, if it hits something of a different density, like glands, it's going to change the sound wave. So there was actually an endometriosis expert that his sonographer wasn't getting as much information on adenomyosis as my sonographer. So I had my sonographer write it down, and then eventually I said, you know what, why don't you talk to his sonographer? Because I don't do my own sonograms, because I'm a surgeon. When I came out of training, I was pretty good with an ultrasound machine, but now I only do surgery. So I let my sonar person do that, the ultrasound person, because that way they have a better way. So the story associated with this, we don't pay very well in our office. So we had a patient, or my sonographer was trying to make a little more money, so she would work in an emergency room on the weekends. So she's doing an ultrasound on somebody that came into the emergency room with pelvic pain, and she's looking, and in the cul-de-sac back behind the uterus and the rectum, that area is called the cul-de-sac. She saw some adhesions floating in there. So she put that in a report. Then she saw adenomyosis. And about 5 minutes later, the radiologist comes in, bangs open the door and says, "Get that out of there." He didn't want it in there. Why? Well, because one, adhesions, he would have to explain adhesions and why he saw adenomyosis to the physician. So this way, by taking it out, then it's not there. So to me, sending the sound waves through the muscle is 1,000 times better than like looking at this cup and trying to determine what's on the inside of the cup. Like doing surgery, going, "Oh, I think you have adenomyosis." Yeah, you can get an impression, but what's better, looking at the outside and getting an impression, or sending sound waves through here? Sending the sound waves through. By the way, it's empty now. Had coffee in it. So you can't tell by looking at the outside. So that's why, and even though I go through this with my patients, one of the first things they go, "So did you see adenomyosis? Do you think?" I'm like, "Oh my gosh, look at the ultrasound. She drew a picture for us." So yes, I still will dictate if you could look at the outside and get an impression, but that is not the best way to give the patient an idea whether it's there or not. Now, one of the questions that had come up is, do I consider this a progressive disease? Of course. So is endometriosis. Recently I did an ultrasound, actually just a patient from Friday, from yesterday. Hadn't seen her for a while, for a few years. And the first time she came in, she had mild adenomyosis. And now it's moderate. By the ultrasound technique and definition. So yes, I think it's progressive. So is endometriosis progressive, and I've not ever seen although I've heard of and discussed with a mom, a patient that had endometriosis in their lungs at 16, but that's not the normal process. But so another question is the MRI more sensitive? I don't think it's more sensitive than the problem-focused ultrasound in the right hands of the person doing the ultrasound. There's one area that I like the MRI a little bit better than the ultrasound, and it's right between the rectum and the vagina. Because trying to get the vaginal probe up high enough with the symphysis, the bone in the front in the vagina, is not quite as accurate as the MRI for that area. So if it's up to me, I want an ultrasound more than an MRI. But if I can have both, oh my gosh, that's so much more informative. But I see so much more adenomyosis with our ultrasound than I would ever see with an MRI. I think some of the data out there says that but if you get an MRI, about 30% have adenomyosis, and in our hands with my sonographer, it's much higher than that. Because to me, if they have endometriosis, they have adenomyosis, and if they have adenomyosis, they have endometriosis. Not 100%, but one to me is given as the other, because in my opinion, they're not different. It's just a different location. So let's see if was there another question here? Somebody just wants to make sure if evidence of adenomyosis seen on my MRI, they can't necessarily know what the abnormality on the MRI was. Well, if you see it on MRI, then what they're looking at is the sound wave, the magnetic wave looking up some cells that are different than the muscle cells. So what else could it be? It would probably not, to my mind, anything else other than adenomyosis. So yeah, if they see it on an MRI, to me, you have it. Now, I wouldn't diagnose somebody with it on a sonogram or an MRI because you haven't seen it, but it's there. Just like, when I talk to somebody about their symptoms of endometriosis, if they have every single symptom of endometriosis and their family members have been diagnosed with endometriosis or the same symptoms, then guess what? They have a neon E on their forehead telling me there's endometriosis. But until I see it, I'm not going to cut it out. I'm not going to give them that diagnosis. So, all right. So So far, we've talked about who gets it, which in my opinion is pretty much the majority of people with endometriosis because it's the same. What are the symptoms? And then, of course, how do you diagnose it? And again, the specific diagnosis is pathology. But, there's always a but. Just like surgeons, there are some that are better than others. Radiologists, as I just described that little vignette. Same thing with pathologists. We have 3 pathologists at our hospital, and they are related. You have a dad and two daughters, and one daughter is really good at endometriosis. The dad is pretty good. He's smarter than the other 2. So if you have a question on the pathology slide, he's the one to go to. Endometriosis, the one daughter. The other daughter is kind of in between both of those. But guess what? When they take a uterus, they don't do 360 slices. They kind of like cut it in half and maybe cut it in half again. So you have 4 pieces of an apple. And then they look at there. So if oftentimes they'll look and they'll go, oh, I didn't see adenomyosis. That doesn't mean it's not there. It just means that they didn't see it. And that's why, in my opinion, the ultrasound is better than even pathology because it's going to give me more information. It's going to look at more surface area of that uterus than a pathologist ever would. So let's see. Another question. Is there any correlation between an IUD and adenomyosis? In my opinion, adenomyosis is not retrograde menstruation, okay? So if there's a correlation, I'm not saying you couldn't get it, just like if somebody gets an endometrioma in their C-section scar, that might be from the lining of the uterus. It might not be, but it might be. And the same thing, if an IUD erodes into the muscle of the uterus, then maybe it could take some cells with it and maybe have some symptoms of adenomyosis. But again, to me, it's totally different. There's a video, and I tried to find that video because I just find it fascinating. It's a really great animation. And I'm like, it would make me a believer if I didn't think differently. It was somebody that showed a complete animation on how like a D&C or a C-section had these cells migrate into the muscle. It's not different. It's the same. I know we can call it different. We can say, oh, it's the cousin of endometriosis. Why would we say that? It's glands where it doesn't get. It's hard to get to, which we'll be discussing in a few minutes. But in my opinion, it's not any different than endometriosis. So yes, you could potentially, with an IUD migrating in there, see some cells grow there because it maybe developed a tract, but that's not the typical way that it gets there. So, all right, looks like another question here. You're saying that it is not normal endometriosis, and neither is endometriosis. And of course, the world, I can't say the world, at least half of our endometriosis experts and the rest of the world do say that it's the lining of the uterus from 100 years ago. So I'm being perfectly clear. Endometriosis is not the same as the lining of the uterus. You don't have to agree with me. You don't have to believe me. And if you go to your doctor and ask him, he's going to tell you it is. I don't care. It's not. And there's other data and my data that says the exact same thing. So I hope I was clear on that. So it's another question is, would it be accurate to say adenomyosis is endometriosis of the uterus? Well, it's endometriosis in the muscle of the uterus, because you can have endometriosis on the uterus. So again, it's still, in my opinion, endometriosis. If somebody wants to give it a different name, I don't have a problem with that. But all they're saying is glands in the muscle where it doesn't belong. And if you tell me that's different than endometriosis, You could say it, but I'm probably not going to believe it. Just like you may not, whoever's, still a little unclear, if you don't want to believe me, that's okay. I just want you to at least think about it, because why are these cells so different? That's, it's just so. I had patients born or with their first period having pain. They haven't had retrograde menstruation. I wasn't going to get into it too much, but the receptor status of endometriosis is different than the lining of the uterus. There is published data on there all the way back to 1978. Tamaya, T-A-M-A-Y-A, Dr. Tamaya published a paper. I think it was only 19 patients. And they said that the receptors, if you've ever heard of breast cancer, they cut out breast cancer and they check it for receptors. They check for 3, but there's only 2 that in the endometriosis world we should be concerned about. One is called HERS2, it's a protein, but the other 2 are estrogen and progesterone receptors. Okay. So Dr. Tamaya, and I think Dr. Metzger was in on that study also, but Dr. Tamaya said that the endometriosis receptors are different than the normal lining of the uterus. It's called eutopic versus ectopic. They're not the same. And to sit there and think that they're the same, if it was retrograde menstruation, it would be the same. But I have found in the last 17 plus years that 75% of my specimens are positive for both estrogen and progesterone. Guess what with breast cancer? 65% are positive for both estrogen and progesterone. And I just had 2 patients in the last 3 or 4 weeks where with endometriosis, no receptors. So they're not going to grow with hormones. Not going to grow. These are different than endometriosis. And in the same patient, different receptors on different areas. So it's not even the same disease in the same patient on how it's responding to hormones. To sit there and say, oh, it's lining of the uterus, I don't agree that it is. So why do I think it's so hard to get agencies to get the definition correct? I'm going to deny this, even though it's being recorded, because we're idiots. I'm sorry, we were saying this before. I don't like doctors. I include myself. I don't like myself. We're the most educated, stupidest people I've ever met. We say things, and sometimes you probably can't get the effect of pulling answers out from somewhere behind me. If we don't have an answer, we'll try and fill it in, and it's not, it has to make sense. And that's what's lost in medicine, the sense. So why? Because things are, that nobody wants to change. 2 quick examples with this. One is in Australia, back several decades ago, there was a doctor down there who ended up winning the Nobel Prize. And he said that, guess what? He thinks that ulcers are caused by bacterium. He was drummed out of medicine. He was literally called a quack. So what did he do? He gave himself this bacterium and he got ulcers. It's called Heliobacter. He got the Nobel Prize from it. Okay. When I was looking into that, I looked back and thought, is he the only one that ever thought of this? No, many other doctors did. But you know how they explained it away? Contamination. Oh, there's bacteria. Oh, it was contaminated. So instead of opening their minds and saying, wait a minute, no, I've got a good explanation. It's a contamination. It has to be acids that do it. Let's change your diet. Let's cut the vagus nerve so that we could have more surgeries. So that's the first. The second is back in the 1700s. So this isn't a new phenomenon. If you delivered a baby in a hospital, or if the woman delivered a baby in the hospital, almost everybody died. It's called puerperal fever. If you delivered at home with a midwife, pretty much everybody lived. All of a sudden, one of the doctor's patients started to live. You know what he did differently? He washed his hands. Washed his hands. And all the other doctors were angry at him. We're gentlemen. Oh my gosh. He died a pauper because he was drummed out of medicine. So, a long answer to say, because we're dealing with people that are hard-headed. They don't want to change. Oh, this is I've been through it a couple times in medicine already with laparoscopy. I finished my training in 1986. Laparoscopy was still in its infancy. Okay, we didn't have a lot of instruments. And so I watched the medical profession laugh at laparoscopists. Oh my gosh, you guys are cowboys, you're idiots. You're going to kill people. Okay. Then all of a sudden it became a standard of care. Look at an appendix or gallbladder. That's the way most things are done these days. And then about 14 and a half years ago, a little bit more than that, almost 15, I started to look into robotic surgery. And guess what? We were laughed at. We're idiots. This is ridiculous. They'll think up every reason in the world to say, don't do robotic surgery, but it's better. I know other doctors are going to say, no, it's not. It's better. I don't care who the doctor is. When you really look at the differences between one eye and moving instruments opposite to what you normally move, looking at a TV screen, I'm sorry, the robot's better. But so a long answer. You can tell I'm not passionate about that. So somebody said about the receptor differences. You got to understand how endo is not cancer. Well, how do I explain that? It has a component. There's two things in of cancer. One, it metastasizes, and two, it takes over the function of the cells where it gets. Endometriosis doesn't take over the function, but it does seem to spread, in my opinion. It metastasizes. So again, you have to look at the receptors, and of course, many of the experts that I talk to try to convince them to do it. They're like, well, I get rid of 100% of the endometriosis, so I don't need to know what the receptors are. That's a whole different story there. So along with that question is, are immunomodulators being considered as therapy? Yes, they are, but they were considered even a long time ago. But certainly as time goes on, we find more and more things that can do it. They're attached to, it was for this split second, it would destroy glandular cells, and you could attach it to an immunoglobulin, and it would attach to glandular cells, and it would destroy it. But when it was done in the early 90s, then you couldn't go out in the sun for like 30 days. So yes, some of that stuff is being looked at, but there are when we look at endometriosis, there are other things that we have to look at besides endometriosis, such as adhesions. But again, we'll be here for hours and hours if we get up in that direction. So now let's look at how do we treat adenomyosis? Well, it's hard, very hard, because again, thinking about a watermelon is how do we dive into a uterus and start cutting them out? Well, there are some docs that, the first one that I'm aware of was in Japan for severe adenomyosis and fertility, some pain, but fertility. He would actually open up the uterus, cut it open, and then scallop out the glandular cells, because if it's severe adenomyosis, there's hardly any muscle there. And scallop it out and then sew the uterus back, and they had some potential pregnancies or good pregnancies. There was a doc in St. Louis that did it, and I think they stopped. Dr. Vidali says he sometimes do that up in New York. I don't think it's a routine thing to do. Certainly for what I do, I don't do that. I had a patient who had severe, severe adenomyosis. In other words, it was almost like oozing out of the uterus. There was so much of it. And very difficult surgery. She, I think, has a 3-year-old now. How she got pregnant, that would believe that this infertility doc was a magic worker. But I called her obstetrical doctor when she was pregnant and said, listen, I really think you need to do a C-section because there's no muscle. This is all glands. And when it comes time to trying for the uterus to squeeze, it's going to find the path of least resistance. Well, it was like, oh yeah, okay, sure. And the OB doctor hung up the phone, right? Well, the outcome was good, but as like he was getting ready to deliver, her epidural wasn't working because she was in agonizing pain. Of course, it's her fault that it's not working. So of course her uterus ruptured through those glands, and they did an emergency C-section. But mom was fine, baby was fine, everything was fine. But that just shows you that this uterus is muscle. But when those glands get in there, and of course, if you dig out and scallop it out, there's not a lot of muscle there anyway. So that would probably preclude, vaginal delivery. And probably as soon as the lungs are mature through like an amniocentesis, then you get that baby out of there before she goes in the liver, because it's probably going to rupture with, when you cut the whole thing in half and sew it together without a lot of muscle. So that's about the only way you can get to it without destroying the muscle of the uterus. So somebody asked a question, so is it possible to conceive and deliver successfully? Yeah. I wasn't going to go into this too much because I'm going to parrot what one of the infertility docs said to me, and Dr. Braverman, he passed away 2 years ago. But he educated me a lot. And this kind of goes along with one of the questions about cutting out endometriosis, even with adenomyosis. He found that a baby is a tumor, especially when they become teens, by the way. But I have 5 daughters, so yes, stick needles in my eyes until they become like 20 or 21. From 13 to that age, it's like, oh my gosh. So, but genetically, that baby is different than the mom. So why doesn't it get rejected? You can't take those cells and implant it into your arm. You're going to reject it because, one, the uterus is unique. So you can put things inside the cavity, like an IUD, that sets up an inflammation, but it doesn't get, quote, rejected. Plus, the placenta has amazing properties to it. Okay, so part around the baby, slippery. The underpart, the chorion, stimulates patient stem cells, and it has an abundance of interleukin 1 and 10, which are anti-inflammatory cells. So what he taught me was that it's a hostile environment. When the embryo is small, before it's become a fetus, it really, in his opinion, didn't stimulate the immune system very much. Okay, so once it implants and starts to grow, now that's a hostile environment. And until the placenta is big enough, that is at risk for a miscarriage. So he said, you want to get out all the endometriosis you can so that there's less stimulation of the patient's immune system. And so, in fact, he said, even with the robot, with the 3D and the 10 times magnification, if the cul-de-sac looks normal, he and Dr. Vidali did a study where they eradicated that area. I like to cut it out. I think in the study, they only ablated it. But they had higher success rates. Again, I'm just parroting from what he told me. I could be off on some of this. And they had higher success rates in delivery or less miscarriages because there was less hostile inflammatory cells trying to get rid of that pregnancy. So, so that goes along with it. You want to get rid of all the endometriosis, but you do see an increase in miscarriage rates with the adenomyosis there. And an example, I had a patient that had an adenomyoma, had severe adenomyosis, severe endometriosis everywhere. I mean, adhesions everywhere. Really, really difficult case. This person had tried in vitro a few times, never had been pregnant, ever, ever, ever. Cut out the adenomyoma. She was a patient, Dr. Braver, in this. Cut out the adenomyoma because I said, "Are you sure you want me to cut into the uterus?" He's like, "Yes." Okay. Couldn't get the adenomyosis. And I did what's called a second look, which that might be a different time. So did everything we were supposed to do, went back 5 days later, and then she went home and on her own got pregnant, but just miscarriage, and now has, I think, a 2 or 3 year old child, and I think even another pregnancy. I don't know if that was on her own or with assistance, but here's somebody that never ever been pregnant. When you get rid of the disease and the adhesions, is able to get pregnant on her own. So a long answer to is it possible to conceive? Yeah. Another question here: can there be hints of possible adenomyosis on MRI scans? So a certain time during the cycle? Well, of course. The more inflamed these cells are, then they might, just like anything, swell a little bit. So sure, when your pain is at its worst, then maybe right before or during your cycle would be a better time to look for it. Same as with the disease. I know there are some docs that like to put patients on ovarian suppression medication to try and have the less inflammation. I'm like, no. Don't mask any of the disease for me. Let it be really, really bad. So does the amount of disease correlate with pain level symptoms? Just like with endometriosis? No. Does it minimal endometriosis equal minimal pain? No. The same thing with endometriosis, which, even though they're the same, in my opinion, that no, you can have one dot and be doubled over in pain, either from adenomyosis, endometriosis, both, or all of it. So, all right. So now we talked about one of the treatment options, which makes it very difficult, is trying to cut it out. So if somebody is done with childbearing and their uterus hurts with periods, as a guy, I'm like, why would anybody ever want to have a period? I mean, I'm sorry, but I'm like, I know medically, yeah, you're supposed to, but I would never want to have a period. So the definitive removal of that organ that has endometriosis in it, adenomyosis, then the adenomyosis is gone. Okay? And of course, no more periods. But if somebody wants to maintain childbearing or just keep their uterus, then you've got to do something else. So, of course, everybody says birth control pills. Well, I keep it on my desk. I guess I could have brought it and held it up. It's on managing contraceptive pill patients. And it's like, okay, you go to side effects and breakthrough bleeding and spotting on birth control pills. And if you look up in that side effect section, there's 4 main reasons that people on the pill will breakthrough bleed and spot. Missed pill, drug interaction, infection, adenomyosis, or they used to have endometriosis in there. So of course, if there's endometriosis and adenomyosis and you're on the pill, you might break through bleed and spot. And of course, if people are hurt when they're bleeding, boy, that's a great option. Yeah, way to go. I'm not a big proponent of birth control pills for this disease, adenomyosis or endometriosis, or however you want to look at those 2 diseases. So, but there are some patients that feel better. Some people can put the Mri Iud in there. It's not treating the disease. The progesterone may stabilize those cells of the lining of the uterus, and those patients may not bleed. And if they're not bleeding or bleed less, they might have less pain. Or you can, if they're done with childbearing and they want to keep the uterus, you can burn the lining of the uterus, called an endometrial, not endometriosis, but endometrial ablation. I don't do those. I don't even put IUDs in. I'd leave that to other docs or nurse practitioners and stuff. So, but you can burn the lining of the uterus, and probably 75% don't have any more periods. Okay. Now, there's other hormones that you can do. One is male hormone. Why not do that? Well, nobody wants the side effects, shrinking the breast, facial hair, like, no thanks. But It will suppress ovarian function and therefore no estrogen or progesterone. And those patients might not have periods, and therefore endometriosis and adenomyosis may not be growing. You can do progesterone only, which is the PMS hormone. So if people don't mind the breast tenderness, headaches, fluid retention, mood swings, and bone loss if you're on it for a year or more, go for progesterone only. Okay. And if you don't know about the bone loss, just look up Depo-Provera black box warning. Bone loss. Yeah. Nobody talks about that, right? They'll talk about it with other medication. And then there's also medication that has no estrogen or progesterone, no periods. There's bone loss with it, but hot flashes, headaches, night sweats, mood swings. And if you have them, the company that manufactures it wants you to go on progesterone or progestin, which is called agestin or norethindrone acetate, so you get PMS and menopause. And of course, you know them, and saying the word, everybody here will probably log off and slam their window shut, is Orilissa, Lupron, Zoladex, the nasal spray, Cinerel. If a patient wants that type of medication, I like Orilissa, because if you don't like it, you can stop it. Whereas Zoladex and Lupron, you give a shot and it's there for at least a month. So those are the mechanical or the medication options. The other aspect, and we got 3 more questions I'll get to here in a minute, is surgically, we can cut a nerve that provides sensation to the uterus. It's called a pre-sacral neurectomy. I've heard some doctors say 90% get relief. I found it more, looking at the data in the 65-70% range, where if you cut that nerve, that those patients either have less or no pain with their periods. You're not doing anything to the adenomyosis, but you're having less pain or no pain. It doesn't affect getting pregnant, doesn't affect pregnancy. And most patients will still have pain during labor because there are other nerves that get to the uterus besides through that area. It's not as difficult as some docs like to say that it is. Again, if you're dissecting out the ureter, you can do a presacral neurectomy. You just cut the nerve. It's right over. It's just above the sacrum. It's a whole bundle of nerves that are in there. Side effects, and the statistics I cite are about 10% can have chronic constipation or chronic urinary frequency. I actually had one patient where I went back in 5 days later for my second look, and there was this white stuff in there. First off, it looked like an infection. I'm like, oh my gosh, did I put a hole in the bowel and didn't know about it? It looked like pus everywhere, but she had no fever. She had no problems. And it was when I was doing the dissection, ended up cutting some lymphatic nerves. And of course, doing a literature search, there's only been 4 cases ever reported laparoscopically, none robotically. If I wasn't a lazy guy paperwork wise, I should have published this, but it's called chylous fluid in there. It's white. There were only a couple options to treat it. Is you just let it alone and it'll resolve, or you can seal it again, those little lymphatic channel vessels, or seal it and put a drain in. And I sealed it and put a drain in, and she was fine. She was fine even with it was there, but again, you don't want that. If you've ever seen somebody with what's called elephantiasis of their leg, or after they've had breast surgery and they can have arms swell, that's because the lymphatic channel has been damaged. So those are the only things you can do to help the uterus symptom-wise. So let's look at these 3 questions. There's a new approach, maybe not so new, high-focused ultrasound. Well, the problem is it going to destroy the muscle? Because I was going to mention you can even put other probes in there, like RF or freezing to try and get it if it's like severe. But just think of sand or pepper in your muscle, just floating around in there. Not floating, but implanted somewhere, not in one specific location. If there's an adenomyoma, you can do that. If it's severe, you can do it. When it gets moderate, I mean, when you look at these cells, these glandular cells, where they don't belong, it's dispersed throughout the whole uterus. So sending the high intensity focused ultrasound to heat it or to freeze it or to whatever RF, radio frequency, any of that, you're going to be destroying regular muscle too. Now, they may be able to change some of that frequency so it doesn't destroy muscle. Again, I'm not a scientist, I'm a surgeon. So maybe they're able to do that, but realistically, to try and pick out pieces of sand may not actually be as viable as we think until it gets to a severe aspect. What are my thoughts on pre-sacral? Oh, I already answered that one. Some doctors do it. I always give my patients the option because of a 10% irritating complication of constipation or chronic urinary frequency. Some doctors, that's part of their scenario, that whatever they're going to do, they're cutting that nerve. I leave it up to the patient. Sometimes after they've declined it and they're having painful periods, I'm like, we could have done that. That might have helped. And then I should have done it. So it's easy to think back. But if you have painful periods, I urge patients to give serious thought to having that nerve cut. Does estrogen in the pill accelerate progression of the disease? You've never heard of my estrogen progesterone receptor talk, have you? So whoever asked that question, Lori, rarely do I ever see an estrogen only receptor when I cut out specimens. I see it once, twice a year. 75% of the specimens I cut out are positive for both estrogen and progesterone. The next most common number of receptors is both. And now I'm seeing more no receptors where hormones won't make a difference. And then, of course, rarely you do see estrogen only that are stimulating this. The most amazing thing is the more advanced this disease is, then I see more both receptors. I don't know if the disease morphs or if it's a disease that will get worse if it's both hormones. In the younger patients, I see a predominance of progesterone receptors. So I don't know if that answers your question, Lori. So does PSN relieve other symptoms besides? No, it's pretty much midline pain because it's a sensory nerve that goes to the uterus. If you have bloating, in my opinion, that's especially if you have bloating after meals, like 45 minutes to an hour after meals, that's adhesions. That's a whole different talk. Sure happy with my PSN. Well, good. I'm glad that you, whoever that was from, that you had it. Okay. Same here. Okay. That was Allison. Okay. So that's my take on endometriosis. I have a whole different take on adhesions, as you can tell, a whole different take on receptor information. If you go on my medical Facebook page, don't go on my private one. You'll probably never want to believe or talk to me again. No, I try to be not too bad on there, but on my professional one. And of course, I don't really maintain it. So there's a lot of stuff you have to go through. One of the things that I want to share is an article that was written by a lady in from Finland. Okay. Oh, no, that's not it. No. Where was it? I just looked at it. That was copy and paste stuff. Where is it? Oh my gosh, where is it? Oh, I know why. I have to bring it up. There we go. Let me close this and then share this screen again. There it is. Okay. This article, she's an author, and it's called Medical Trauma and Gaslighting. It's fascinating how we as doctors, the medical profession, and it's more than that, but doctors in general, we gaslight patients. Like, here's a birth control pill. Oh, it's not working. Let's try another one. Let's try another one. You go to the emergency room. oh, you're drug seeking. And it eats away. It's a very, very long article. Her name is Maija Havisto. And again, she's from Finland. And if you want to look this up, you're more than welcome. It's a great article. I read it. And it goes on and on. Is your pain really that bad? And then people will develop from the micro trauma PTSD. And it's just fascinating how nobody pays attention to this. And I just think it's so important for patients to understand that they have real problems. They have real pain. And you just don't let doctors or nurses or family members, anybody, talk you out of how you feel. There's something going on. Because patients will often say, when we find endometriosis and adhesions and they go, oh, I'm not crazy. I'm like, no, I've never said that. You're just not crazy about what we're talking about. So that's my humor. Sorry, I can't help that sometimes. All right, so somebody said, my bloating is 24/7. Would this still point to adhesions? Well, possibly. It was really fascinating. One of my patients happened to have a brewery, and I was talking about where I grew up in Pittsburgh, Pennsylvania. Go Steelers, Pittsburgh. I grew up in an all-Italian neighborhood, and all of my friends' parents made wine in their basement. My dad didn't, because we had a bar and it was illegal to make wine or beer back then on your own. No, that was not prohibition. I'm really old, okay, but I'm not old for prohibition, okay? I mean, that was 1920s and 30s. So I wasn't a teenager back then. So when we were teens, we would sneak down, we would scoop up the fermenting grapes, drink it and think we were drunk, stagger around. It was probably carbonated grape juice. But when we bumped these fats, the vibration from our walking or scooped it, it would bubble. And what I found, and actually saw my event happen when I was in Nigeria, usually in the large bowel, there's a lot of fermentation going on. And when the intestines are stimulated by exercise, eating, or drinking, then they bloat, because it takes about 45 minutes to an hour in most cases for that portion of the intestines to start to squeeze, called peristalsis. And then it would push that. A lot of patients become constipated because if it's stuck, if it's glued, like in the movie Dumb and Dumber or the movie Christmas Story, where their tongue is stuck to the pole and the intestines start to squeeze, it can't. So you're just stirring it up. And the stuff above will eventually push the stool down. But it's sitting there stirring up that fermentation, and you get a release of gas. And that's why a lot of people bloat. When it's 24/7, most of the time, it's adhesions. I just did surgery yesterday on a patient who, horrible pain. She was spiraling down, and chest pain, back pain, her arm was going numb, everything. And when we were talking about it, because we'd had a VATS done at the same time, video assisted thoracic surgery, and it was almost pristine in there. We cut out one area that looked like it had a potential to be endometriosis, but she had no endometriosis on her diaphragm, not on her liver. But we were discussing in the office before the surgery, the day before, I'm saying, this might be adhesions. Got in there. Her uterus had adhesions to the sidewall. Her ovaries were stuck. To the pelvic sidewall, which sometimes will give hip pain when the ovaries are stuck. They were really stuck, and not many adhesions anywhere else. She had some cul-de-sac adhesions, potential some endometriosis. But guess what? This morning, her shoulder pain's gone. Her chest pain's gone. Yeah, it was adhesions. Adhesions. So for we as doctors to sit there and blame everything on endometriosis, yes, it's a horrible disease. But even worse is endometriosis. I'm sorry, adhesions, because that is a normal healing process of the body. Endometriosis is abnormal. Adhesions are normal. So a long answer to the question is, her bloating's 24/7. Could it still be adhesions? Maybe. I don't know, but maybe both. But if everybody talks about their endobelly, where they wake up in the morning and their abdomen is flat, and they eat, and all of a sudden they look like they're pregnant with their abdomen sticking way out, I'm like, wait a minute, how's that endometriosis in 45 minutes, in an hour? I mean, what type of disease that this is so abnormal that you can eat food that's inside your intestines and magically it makes people bloat? No, the fermentation makes more sense, because when I was in Nigeria, I was talking to somebody that had a bowel resection over there, was extremely thin, was like a model, and had a blouse on. And I was telling her my theory, and she couldn't eat if she wanted to go on the runway because she would bloat or pass out from the pain. So I'm telling it, and as she's eating, she has this blouse on, and I'm watching her belly grow. By the end of the meal, we almost had to carry her to her car. So I've seen my theory in action. I've seen it when I've been operating, and you could see the intestines when they peristalse in that area, and maybe even sometimes start to inflate themselves. So we say things that don't always have a lot of reasoning behind it. We just need to make a reason why something's happening, whether it's right or wrong. So I don't mind talking. I'll keep going. If anybody wants any more information on endometriosis, my viewpoint, my receptor information, my adhesion information, my second looks, what barriers I use, I mean, I'll stay here and talk forever. Questions? I mean, let me know what you want. If you guys want me to do it.
Thank you. This has been really informative. Yeah, so we're just about out of time, but we can, stick around if anyone has a few more questions. Thank you so much for giving us your time to do this.
No, I don't mind. I hope I didn't offend anybody. I always do. But
it's always nice to get different perspectives and viewpoints on these diseases, because
no, I agree.
There's so much information. It can be really challenging to make sense of all of it.
So somebody did have, no, I guess it wasn't a question. So
we really appreciate you.
Okay.
You have no idea.
The problem is when you go to other experts, other doctors, anything, they may not have the same thought process that I have. Mm-hmm. Don't fight with doctors. Mm-hmm. I've tried to get many of my colleagues and friends to do receptor information. I know Dr. Vidali is doing some. And I think he's actually doing it in a more scientific way than I am. Because I taught March a year ago, we had the Endo Summit, and I was up there and I talked to his research person, because they weren't doing all the things to the cells that I was doing. Remember I said my one pathologist that really knows endometriosis, she made up a graph that they use for breast cancer. So what it does is it shows what cell it is, okay? Then it shows whether it was positive or negative for receptors. So they do estrogen and progesterone. So on the cell line, we look at 5 different cell lines. We look for endometriosis. We look for glandular cells. We look for stromal cells, fibroblasts, and mesothelial cells. And Dr. Guan, when he was up here last year, was so fascinated, and Dr. Eugenio from St. Louis was here, and I showed them some of my information, and they were fascinated, and we talked about doing a study, but of course, then we got locked down, and as typical doctors and guys, it's out of our heads, we don't think about it anymore. But no, they were fascinated. They didn't understand that mesothelial cells and fibroblasts could have hormonal cells to them, receptors. And one of the questions I have, which would need an expert, is, well, maybe these experts that are scientists can look at it, maybe they're precursors. Maybe that's why you can have surgery with an expert, go back and find endometriosis in the same area that they cut out. Maybe it's deeper cells, fibroblasts and mesothelial cells that then change into metaplasia into glands and stroma. I don't know. That's for the smart guys to do. Okay. And then besides the 5 different cell lines, then we look at the percentage of staining, whether it's 100% or 10%. Then it also looks at the intensity. I don't know what that means, because they asked me that. Patients like, look, the intensity in the progesterone is either greater or equal to estrogen. The progesterone seems to always be the same or more than the estrogen intensity. I'm like, I don't know. Maybe that means that it has more an impact. I don't know. So I went to my pathologist. I said, what does this mean? She goes, I don't know. I don't know. But I looked it up on the breast cancer. I went to breastcancer.org. You want to talk about gaslighting? They gaslight on there. Yeah, I'll get to that in a second. So, what it says on the intensity on the breastcancer.org is how it takes up the stain. So I do interpret that to mean how it reacts to the progesterone. It seems like it would have more of an impact. I don't know, but how does breastcancer.org gaslight? So actually, I think I can share it. I think I have that right here. Let me see. There's Tesla fire and Texas crash. Oh wait, that's not. So this is how to read hormones, and this is from the breastcancer.org webpage. So let me share this. Okay, share screen, and where is it? Here it is. Okay, can you guys see this? Okay, so let me go to here so you can see. I just have it enlarged, breastcancer.org, and then I just how to read hormone receptor results. Okay, so let's scroll down. This is why I don't like doctors. I don't like anybody. I mean, including myself. So what does it mean? Okay. So the first thing, I don't know if you can see that, about 80% of breast cancers are estrogen receptor positive. Wouldn't this scare you to death to not take estrogen? I mean, don't take estrogen, right? Okay. Can you guys see that though? Okay. All right. The next one is about 65% of breast cancers are estrogen receptor positive and progesterone positive. 65%. Okay, let's look at the next bullet point. About 13% of breast cancers are estrogen receptor positive, negative, estrogen positive, progesterone negative. So what they've done is they took this 13%, added to 65, 78, rounded it up to 80. Okay. The next one is progesterone only. Okay. And there's only 2% that are this progesterone only, estrogen negative, but they didn't add it to the 65, get 67 and round it up to 70. No, they just left it at estrogen. Here's the fascinating one, that 25% of breast cancers have no estrogen and no progesterone receptors. So when I'm looking at this, 65% are both. What hormones would I want to avoid? Both. Then the next month is 25% have no hormones, no hormone receptors. So the third category, 13% of breast cancers, but I'm more worried about both or none. So that's how, in my opinion, that we get gaslighted. Doctors, everybody, 80%, no, 65% are both, 25% are none. That's a significant portion of breast cancer. And to sit there and scare people over estrogen, I think is wrong, totally wrong. So I can't help it. I get passionate. So as I had mentioned, I think I cut out all, if not most, of endometriosis. I know experts say they get it all, and then in my sarcasm, like, well, stop operating on endometriosis patients, operate on cancer patients, because I know, look at all the lives you're going to save because you're so good. You can get every single abnormal cell, 100%. No, experts do the best job for this disease, just like cancer specialists do the best job for their disease. Nobody's 100%
Right.
every single time. Nobody. So,
and I think that that's really important to talk about is, you want someone who's really good, but you also have to manage expectations of patients.
yes.
And no one, even the best of the best, aren't going to be perfect. And even the best of the best aren't going to be the best all the time.
Oh, I agree. Because some of the experts say they're 100% of the time, and then when you push that person, then they go, well, I get 98%. I'm like, wait, if you can get 98%, that means you knew you left 2% behind. Why didn't you get that? We just say numbers so that we look good or look better. No, but they do the best job. I'm not saying they don't do a great job. So if there is some disease potentially in there, if you have a concept of what your receptor status is, then that gives you a better way of potentially managing some of your symptoms post-surgically. I wish I could get the adenomyosis receptors so I would know, but I can't. I'm trying to think about the lady with the adenomyoma, whether I did it. I think I did, but I can't remember right off the bat. But again, when 75% of the specimens are both, then what hormones do I want to avoid? Both. Okay. Of course, ACOG says birth control pills, right? Would we ever give birth control pills to a breast cancer patient that had estrogen and progesterone positive? Never. That'd be the biggest malpractice ever. But let's do it for our endometriosis patients. It just frustrates me because it's clear to me. And if birth control pills fix this disease, then everybody'd be better. And they're not. How many women do I do bowel resection on? More than I want to count, that have been on continuous birth control pills and have to cut out their intestines. It's growing on maybe a little bit less than their own ovaries, because to me, the cyclic manner is worse than giving them together by just like a little bit. But I don't want to give birth control pills. So, and then of course, the younger patients, progesterone, and it's the PMS hormone. It just so frustrates me because, in the world of medicine, estrogen is a horrible drug. You look at breast cancer, what they said about that. And endometriosis, everybody says it's estrogen. Well, if avoiding estrogen really, really was the answer, I'd be doing something else because everybody'd be better. And they're not.
I think that there's probably some really good social commentary there on avoiding the female hormone. Goes along with some of that gaslighting.
But progesterone is too. I mean, when somebody's in menopause and they have hot flashes, headaches, night sweats, mood swings, hair loss, bone loss, what do we give them? Progesterone. And guess what? They feel better. I don't know. It's just, I'm not enamored with medicine. As you had mentioned, I was a pilot before, and I always joke and say, if pilots flew airplanes the way doctors practice medicine, would be running like this if the airplanes flew out of the sky. But one of the reasons they don't is the doctors aren't in the plane. The pilots are in the plane. So they're much more careful, because the doctors aren't getting, adhesions from your surgery or so yeah, I don't know. I always treat your patients the way you would want your family treated. And You're still going to make mistakes. You're still not going to be perfect, but we can't just do what we've always done because it ain't working.
Right. Well, thank you so much. It's so great to have people who are doing things that do seem to be working a lot better than the status quo. So we really appreciate you taking the time to talk to us, to educate us.
One of the things to mention when you said that some patients are getting better, they do. But there's a lot of patients that have been to an expert, and 3 to 6 months after their surgery with an expert, they have pain. And of course, it can't be because they have endometriosis because he's an expert, well, or she. No, that's usually adhesions. 3 to 6 months, by 8 months, you're right back where you were. That's scar tissue, adhesions, the healing process. But some patients, again, even by our experts, were gaslighted. They're told it's not endometriosis. My patients don't get adhesions. You better go to a GI doctor and physical therapy. Physical therapy helps some patients. I'm not saying that because pelvic floor dysfunction does exist. I just think doctors use it to say, hey, I'm a great doc. So.
Yeah, it's that, when do you look at the multidisciplinary aspects and when do you say you need to go back to the OR? And I think that's a really hard place for a patient to be.
It is. And that's why, just being told my patients don't get adhesions. I'm like, so your patients don't heal? I'm sorry. The body doesn't know good from bad healing. And when you take the gas out after surgery, it's like spaghetti and meatballs in there. It's all touching. And so, things stick and docs don't understand because we're not taught that. And the funny thing is, they'll believe the literature on that, but they know that burning endometriosis isn't the best way.
Right.
Cut it out. Why do we as experts in endometriosis want to believe everything else? Like, oh, just go on birth control pills. But wait, why are we believing that data? It's just fascinating. Is there a way to prevent adhesions? Don't heal. Your body doesn't know good from bad healing. The good thing is, in maybe about 8 to 10 years, and now I have to add maybe to it. In 2019, my classmate from medical school, who I'd been in contact for about 2 years, discussing his discovery, won the Nobel Prize in medicine. He discovered this thing called HIF1, hypoxia-inducing factor. And his name is Greg Semenza, Semenza, if you want to look it up. But we weren't best buddies, but we were friends in med school, and he's really smart. Okay, you don't win the Nobel Prize just being some guy. So what he discovered when I found out about it, I looked into it. There's a guy from Michigan who does research on pigs on adhesions, because we use a pig model for adhesion development to see what works, what doesn't work. So at the time, genetically, they turned HIF1 on because it's hypoxia-inducing factor 1. So when you're hypoxic, HIF1 genetically turns on. When we get oxygenated, HIF1 turns off. So they genetically turned it on in the pig, went in, denuded the peritoneum, went back in, no adhesions, no scarring, no fibrosis, which is impossible. Right? None. And it triggered a memory from 1991. It was a good outcome, but I'll kind of shorten it if I can. I had a patient that had a problem. I was doing OB back then, and the baby had a problem. At the time, it was almost 100% fatal, but since we found it, it was a good outcome. And they were doing fetal surgery on this problem out in Loma Linda, California. So I called out. I was going to send her, and they said, "Oh, she's too far along." And they said, "Here's something that's fascinating. Is when we operate on a fetus before 24 weeks, they're born without a scar. After 24 weeks, they have a scar." And nobody figured it out, even up until 2019, right? I went, oh my gosh. So I wrote my classmate an email, and he goes, "You're spot on the no scarring." He goes, "We never thought about this. At 24 weeks and before, the fetal skin is hypoxic. It is so thin, there's no capillaries, there's no blood flow." And then I went and I extrapolated even more. I said, "Oh my gosh, think about it. The first thing to develop in a fetus is the notochord, like the spinal cord. There's no oxygen. There's no blood flow. How about the heart developing? There's no blood flow. There's no heart yet. And of course, when you're an adult and you have damage to your heart, does the muscle grow back? No, because HIF1 turns off when it's oxygenated. When HIF1 turns on, it scars. Somebody's had a heart attack. That's a problem. Strokes, limbs cut off. Take a salamander and pull its tail off. What's going to happen? A tail's going to grow back regularly, not scarred, fibrotic, because genetically their HIF1 is probably on. So I wrote to my classmate, he goes, "You're spot on." And he goes, we're doing a study that he already started, where they're taking rats and they're burning them and cutting them, and there's a chemical way of turning it on. So that was in September of 17. So in April of 18, I wrote him an email and he never answered me. But last Monday, we were having a webinar. So I said, "So great." Typed him in a message just like you guys, we were Zooming. So I said, "Can you now share the data?" And he kind of hemmed and hawed around it and just said that it's just hard to get things through the FDA when you're messing around with gene therapy, even with a chemical that's easier to get through the FDA than just doing gene therapy in general. So so think about it. If you have surgery, you take this and maybe the peritoneum will grow back as normal, because 60% of bowel obstruction is from adhesions. So a long discussion on there. Looks like we have another question here. Is there a way to prevent adhesions? So what I do is, one, I use heated and humidified carbon dioxide. And I think some of the other experts do also, because you don't want to dry out the non-surgical areas. I mean, it's like holding your eye down like this and blowing cold air on it. Do it for about 3 hours. That moist tissue is going to dry out. But of course, it's like being in Houston in the summer where it's 99 degrees, 100% humidity, and you sweat, but it doesn't evaporate. And so by using heated and humidified carbon dioxide, it keeps the non-surgical area moist. The next is barriers. Again, if you scrape all the skin off your hands and you put something that you can't stick to in here, then it won't stick. But if you kept your hands like this for about a couple of weeks, they're stuck together. Okay, so a barrier can try and stop that. But what's out there that's indicated doesn't work. It's called Interseed. It's indicated and it's super glue. It's actually a leaf. It's regenerated cellulose, plant cell wall. Look it up. Interceed. And of course, in the mid-90s, they got approval by the FDA. It doesn't work. So, in fact, if anything, I think it makes more adhesions, but some of our experts are still using it. I've tried everything. I've used spray gel, which is a polyethylene glycol polymer. Tried everything. What works the best, but it's still not perfect, is amniotic tissue, but it's expensive. Remember how I described earlier in the discussion how it has some unique properties of anti-inflammatory cells, faster healing, amniotic side slippery, but insurance companies don't want to pay for it. And they use it in eye surgery, neurosurgery, wound healing, and burn victims. So I didn't come up with this concept. And then, of course, the second look. So what happens is I go back in, I do my surgery, then I go back in within 3 to 7 days. And I found 5 days to be kind of like the sweet spot, and pull apart any adhesions that have formed and reformed. What's fascinating, and if I again wasn't lazy paperwork wise, I would do a study, but I'm too lazy, get the permit and everything. And, but my patients, especially a day or two before the second look. I mean, I just had this Tuesday and Wednesday. So Tuesday, I saw the patient for her second look. And Saturday, because I keep everybody overnight, outpatient surgery, and that's just easier to control their pain and nausea and everything. So I saw her, she's feeling great. My pain is gone. I feel great. Okay. She felt great Sunday. Monday, she started to feel symptoms. Tuesday, she's having this horrible pain again. And I said, where's it? And she pointed to where it's at. And that's where the adhesions were. And I get back in there, exactly where she was hurting. Pulled it apart. The next day, she goes, pain's gone. So by interrupting that healing cascade of events, there's red blood cells, platelets, blood clots, fibrin, fibrinogen, a whole cascade of events. The theory is it's not smart healing. It can't start all over. So what they do, or by interrupting that thought process, is it can't start all over. And they've done some studies in the Scandinavian countries like Janssen and a few others that some of their first studies were done after 10 days and it was useless. Okay, useless. And some of our experts will say only 5% of my patients get adhesions. Well, he said, this doctor says 5% because they don't ever go back and look again. So they don't know. They're just saying, oh, they're only 5%. They're again reaching back there to pull out that answer because it sounds good. And of course, if they hurt, it's GI and pelvic floor dysfunction. So the literature says some patients 100% get adhesions and some 2%. No, it's about 80% get adhesions. That doesn't mean everybody's going to hurt from adhesions, but about 80% will have adhesions that either had them or didn't have them but had surgery. And when you pull them apart in the Scandinavian countries, within that 3 to 7 days, 70% do not grow or regrow when they look on the third look. So that's what I do to try and help. Again, it's not perfect. I wish it was. That means anywhere from but 25 to 30% are still going to have adhesions. But you have to do something. You can't just throw a useless barrier in there and say, I fixed you. No. Or just that I cut them. Now I got 2 raw surfaces. No, you got to do something. You can't just let those patients suffer. So now it says, what is your take on free blood in the lower stomach, which was found during laparoscopy, retrograde menstruation? Well, I don't disagree that with retrograde menstruation. I just don't think it's a cause of endometriosis or adenomyosis or anything other than, it's finding the path of least resistance and blood's coming out. Blood does not mean endometriosis. Blood is blood. Now, there may be some dead cells in there from the lining of the uterus that are sloughed off, but that doesn't mean that that's how people get endometriosis. So we talked about that in the very beginning. It was the 16th day of your cycle. Doesn't make much sense to you. Okay, I didn't read that part of the sentence, but there's another answer for that is when you ovulate, what can come out with the egg? Blood. Guess what initiates healing sometimes? Blood. So even a normal process can cause adhesions, by the way, but that's why one of my partners at the time, she's retired now, but she ovulated and she had to go to the OR and had a half a liter of blood in her abdomen from her ruptured ovarian cyst. So if you ovulate on day 14, that's where it could be coming from. And blood is a huge irritant. What you might see sometimes is somebody's being active, maybe having intercourse, and all of a sudden they let out a scream like you can't believe, or sudden onset of unbelievable pain. They're curled up in a ball and they end up in the ER because the pain is so severe. In about 2 or 3 days, they're better because the body absorbs that. It's from the blood rupturing and irritating the inside of your abdomen. A lot of those patients end up, if it's on the right side, have their appendix taken out or have the an ovarian cyst removed. So, but if there's a little bit of blood, we usually don't do anything. If there's a lot of blood, then you have to go in and stop the bleeding and or evacuate that blood because it would take a long time to absorb 500 cc. So I hope that, Alyssa, that helps your answer or gives you an answer. So, well, I told you I could talk forever, didn't I?
Great. Do we have any more questions that we want him to cover before we end?
I guess not.
Okay, I think that's it. Thank you so much for coming and doing this talk for us. We love listening to you talk, so we are totally cool with that. We could probably sit here and talk all day. But I know some of you have things to do on a Saturday. So thank you so much. If you want to keep talking to Dr. Dulemba, you can schedule an appointment with him. He sees patients in Denton, Texas. And we've heard really great results from people who have seen you.
Thanks. Well, I try. Just like every other expert out there, I try. We honestly, all the experts are surgically excellent. I just wish they paid more attention.
We'd love to maybe pick your brain in a future talk again, if you wouldn't
Sure.
mind.
Sure. I talk all the time. In fact, everybody's like, "Oh, shut up."
I think we could probably do an entire talk just on adhesions alone.
Oh no, I'm very serious. Yeah. Well, back April a year ago when we were locked down, myself, Dr. Shinovo, and Dr. Apuku from San Francisco, we had a webinar, and it was about adhesions. And I showed a little video. I don't have a lot of videos now because my phone is so antique for recording that I can't record anymore. But it's an older video. And you could go on my medical Facebook page and see what it looks like at the end of a case. And then 1 week later when I went in, and I used to suspend ovaries, and I don't anymore, because if you see stuff grew into the stitch and bile stuck to the ovary, and no, to me it's worse than endometriosis. Endometriosis is horrible. Adhesions are worse because it's new.
Mm-hmm.
So, okay.
Great.
Well,
thank you so much.
Thank you. We appreciate you.
And, everybody, stay safe. And
You too.
thank you for tolerating my my passion and my often different directions.
Thank you so much. We were thrilled to have you.
Thanks.
It's not